Bem-vindo ao Maestria da Mente Podcast, onde abordamos o que há de melhor na neurociência e no comportamento humano. Hi, Dr. Elvira. It's a pleasure to have you here as my guest on my podcast. Dr. Elvira, I'd like to know how did you get into the world of hypnosis?
Well, it was all basically accidentally. While I was at Stanford, I worked at the Veterans Affairs Hospital in Palo Alto. And one day there was this very scared young Vietnam veteran who was too afraid to get on the procedure table. Now, these days, I really didn't know what PTSD was, yeah. But then I saw how a very quick imagery hypnosis intervention made a huge difference. And I thought, this is very, very interesting. And so at the time, our grants director at Stanford, Judy Illes, told me, she said, well, you know, here at Stanford, there is David Spiegel, who is the real world expert in that. Why don't you check out with him a little bit what this is all about? And so we started this project, but, you know, as a clinician and as a researcher, I wanted to know, is that going to work only for this young man we had there, or is this going to work for other people too? Is this something that can be done by my staff? Because I am an interventional radiologist. I did procedures on awake people. It's like surgery. They look at you with these big, fearful eyes. And, you know, as we always say, you have to be able to get the patient on the table, keep them on the table, and be able what you need to do with dignity. So we developed a research program surrounding that. And it was first actually supported by the Department of Veterans Affairs, which now many, many years later is actually an interesting aspect of the whole thing. Where we got really, really more focused on it all is when we had a big earthquake, the Loma Prieta earthquake. And so we couldn't use half of the hospital and the recovery rooms anymore. They were condemned. And now you have the choice. Okay, if I'm giving drugs for surgery, I need to recover the patient afterwards. But since I don't have a room where I can put them, I have to keep them in the operating room. So it takes a long time till I can do the next case. So am I going to go home every night at 10 o'clock at night and come at 6 in the morning? Or do I use something non-pharmacological, don't need as many drugs, and kind of still can have a dinner at home? And that's kind of the route we chose. And then over the years, continued on this program, researched all aspects of it, and that's where we are today.
A fascinating story. And Dr. Elvira, we know there are many definitions about hypnosis, a lot of misconceptions. In your opinion, what is hypnosis?
I think it's a state of focused concentration where you give less attention to what's happening around in the world. It's like you read a good book, you watch a movie, or you're on the internet and suddenly the time is gone and you don't actually really know what happened around you. So it's a similar state, but it also makes you more open to suggestions. And it also makes you more open to explore your own internal thoughts.
Perfect. And do you believe all people are hypnotizable?
Well, I think to a certain degree, we all have states where, given the right situation, we all gonna be able to attain a different state in our mind. Yeah, so, you know, it is, you might say, sometimes it has been said about religion that if you're in the war in the foxhole, there are no atheists, yeah? And so I believe also that if you're in a situation that's challenging enough, pretty much even individuals who never may say they have a tendency to go in a hypnotic state probably are in an altered state.
I'd like to know, you mentioned on Dr. David Spiegel. I'd like to know if you have mentors or people who helped you during your journey in this world of hypnosis.
Well, it's very interesting, and you've probably encountered that too, is that when you start doing that, there's going to be a fair amount of resistance, disbelief, yeah, and possibly even some sabotage in your surroundings if you do this clinically. So you are going to need a certain amount of support, but you also need people from whom you can learn. So I pretty much learned from David Spiegel how one can do that. He has a certain way of using a script, and we actually still use a scripted approach. Who was also very critical was Judy Illes, Dr. Judy Illes, who was our grants director at Stanford. And this was at the time when in the United States, the Office for Alternative Medicine was just founded as an office, which now later become the National Center for Complementary and Integrative Medicine. And they gave out the first request for applications for a grant. And I tell you, at Stanford, you do have to write grants, yeah. There's no way around it if you're faculty. And Judy was trained in psychology, and she actually also went on. She actually is now the chair of neuroethics in Canada. Yeah, so it is a very small world. And then you go along, you meet other people. I joined the New England Society of Hypnosis. I joined SESH. And this is where you learn from other people, like, what can you say? What can you do? And obviously then through the research, you get a lot of collaborators. And in a way, that's also the rewarding aspect of it. You all learn from each other. And yes, there have been times where I said, I'm going to stop this whole thing. I'm not going to do anymore. It's just too hard. But that's when you rely on your network of friends.
And when and how did you become interested about the hypnosis specifically to manage anxiety and before surgical or dental procedures?
Well, it basically was a necessity. I mean, after you see this works, you're going to start using it. But keep in mind, when we started doing that 30 years ago, yeah, there was this idea that only a psychiatrist or mental health professional, or interestingly, dentist or social worker would be allowed to do this correctly. And for a clinician, for me, it would have been okay, but to train a nurse, oh, that was considered heretic, and still is by some people in some of the US hypnosis societies, perhaps out of a belief to protect a niche of their practice. But, you know, in medicine, you don't have 45 minutes to put somebody on a couch. And frankly, I think it is much, much harder to do that in the office than hope to get the patient out of the office in a relaxed state and hope the patients can do that on their own when they get into clinic. Where we have the great advantage, and this is why I sometimes call it a poor woman's approach to hypnosis, yeah, or the poor man's approach to hypnosis, is when you're in the clinical setting, you already have a patient in an altered state. And what we find out more and more, that patients who are very anxious, particularly MRI, patients who have real claustrophobia, it is PTSD. They had some kind of an experience in their past that triggers these fears, often medically induced through an experience they had in medicine before. But when we once went out for training and told people in MRI, well, this is PTSD, they said to us, no, we don't believe that. When we came back for the second training, they said, you're absolutely right, because now the patients tell us. So they come to you, the situation triggers their past experience. And so it's relatively easy to reframe it at that moment, because that patient's motivated. I mean, they wouldn't have come if they
Sure.
wouldn't be motivated. They want to be helped.
Sure.
So it is relatively easy. You know, we don't have to do like what a psychiatrist has to do for exposure therapy. Let's say of somebody who comes back from a war or has been abused, yeah. They walk in the office, you first have to get them back into the trauma, you have to change it, and you have to get it out of it, yeah. All we have to do is, we just have to reframe it while they're there in a safe environment. And so you also have to take in consideration that the people who work there, the nurses, the dentists, the technologists, the respiratory therapists, the physical therapists, they have to deal with this patient anxiety all the time anyhow. It's not that that's something they're not used to deal with. So why not give them the means to do it in an efficient way? Now for comfort talk, and the reason we called it comfort talk and not hypnosis is because the hypnosis word is so scary. And interestingly enough, a lot of people now borrow the comfort from us. Everybody does comfort for this, comfort for that. But the key issue is we had to distill this down to observable behaviors and to teachable behaviors. And that had to be validated. And so that's that package that is now Comfort Talk, a set of observable, teachable skills with validated patient outcomes.
Perfect. And what is exactly the comfort talk, and what are the benefits of using this technique?
Well, there are two parts of the story. The one is what you could call the healthcare provider. The other part is the patient. But this is an entity you cannot separate, because if you have a stressed out patient, it will rub off on the healthcare provider. And I've often been saying, if you're in a surgical room, you only have to relax one person and it will rub off on everybody else. So what we have also done, we looked at it, if patients come in with a negative affect, yeah, actually they are going to have more complications. It is going to turn into a self-fulfilling prophecy. On the other hand, we've also done once a paper where we show that if you stress out the patient, if you stress out the provider, the patient's going to be less able to go through their exams. Yeah, so it goes both ways. And nowadays, at the time of the Great Resignation, where a lot of physicians, nurses, healthcare professionals say, we had it, we are not coming back. Yeah. How can you give people the joy of their work back? And the way I hear all the time again is, you know, I had this great experience with this patient today. I'm going to come back tomorrow. And that's what we're working at now. All you need is you just need to have one patient experience today that really made a difference. And that's what we focus now a lot on, to give the staff that is still working the resilience back to endure.
What are the main components of this approach?
Well, the very first thing is you have to establish instant rapport. And when there's rapport and things are easy, that are easy. People find the right words, it just goes smooth. But when it's not easy, every word and everything can be misunderstood and will be misunderstood. So we work a lot when we train teams. We train ideally entire teams in what do you do when you see this patient first? and you get this feeling, there's a lot of bias training now where they tell you what not to do, but they don't tell you necessarily what to do. And, this has happened to all of us. You meet this other person, they haven't said anything, they haven't done anything. You can't really put your finger on it. And you have to get over this like in 15 to 30 seconds. Otherwise, this relationship is over. So we work a lot of that. There is an element of matching the person's state in which they are physically, mentally. And there comes in that you can't separate the expression of someone, how they behave, how they move, how they speak, and how they feel. So we work on very quickly first getting into the state the patient is, but then moving into a more resourceful situation. And typically, if you do this matching and then lead out of this state, the patient follows you relatively quickly. And there's a fair amount of research done on the whole issue of mirror neurons, so we work a bit on that concept, or you create even through your own behavior a, placebo effect, And then every word counts so that you avoid negative suggestions, that you choose words that are helpful for the patient. Let me give you an example. We are training the staff of the Bevolkingsonderzoek in Netherlands. That's the National Breast Cancer Screening Service. And the Netherlands has an enlightened and admirable medical system. Whatever works will be done. The entire approach is data-driven. It has to show it works, And the entire patient interaction for a mammogram is 6 minutes. From the moment the patient walks in, goes in registration, has the clothes taken off, is walked to the machine, gets the exam, and walks out. So you see, there isn't much time for a whole lot of words. But you can see that every word counts. And so what we work in our training, what you say has to work for the patient, but also for you. There are certain things one says or does may work for one person, but not for the other person. So that's what we work at to help staff find their own language, but one that works with the patients that they usually see. Well, we do have a general script. And even if you read relatively slowly, you can do that in 1.5 minutes. But when we do the training, it's sometimes enough to just pick certain sentences from it, depending on how much the person needs. What we also do when we train a team with Comfort Talk, we establish a portal for them where they have suggestion cards, what they can say in certain recurring situations that commonly come back, where they actually work out in their group and for themselves what is a good way to say. So let me give you an example. So we were training the MRI team at Tufts Medical Center here in Boston, which is right next to Chinatown. So one of the challenges for the MRI technologist is that, let's say it's Friday night, people going out for a drink, for partying, and then they kind of walk, they fall off the pavement, they trip, they fall on their head, they go to the ER. So obviously, they gotta get an MRI scanner. So if you in the middle of the night and you're a technologist alone with a semi-drunk person who doesn't want to get on the table, it's a different kind of vocabulary and approach than you might be using in a practice we trained in the outskirts of Columbus, Ohio, where they live very wealthy people. If you think they only live in New York, no, this is where they are. This is where you have the women who come to your MR scanner who have their lingerie flown in from Paris on their own plane, yeah. And so you want to ask him to take this bra off, which has this little metal piece with a diamond on it, yeah, because you can't have the metal in the MRI scanner. It is a very different vocabulary than you are going to be using for the gentleman who is drunk at night in Chinatown. Or if you have somebody who comes for the football game, yeah, and gets, hit and needs an exam. Or again, you have somebody for a routine exam who has clear PTSD and you need to do some reframing. So it is geared to how can I get the patient on the table, number one. And then how much do I need to do? Is it going to be as good as if I have a 45 session with Dr. Spiegel on the couch? Probably not. But our goal is not to change people's lives. But, well, we get them through the procedure. But what we have seen sometimes, it does change people's lives. I mean, we actually had one MRI technologist cure a patient of PTSD where she couldn't go into a closed room for the last 11 years. I mean, clear
Amazing.
abuse history. Yeah. So
you talked about the comfort talk for the clinicians in general, how to use this approach with the patients, and how the patients can have benefits using the comfort talk scripts before surgical procedures. What would be the main components of this approach?
Oh no, the beauty is all you need to do is at the beginning. See, this is the secret sauce why Comfort Talk works. And we've done a lot of research. So we did publish one paper where we looked at what happens under standard of care. So we had 3 different procedures. The one was vascular and renal interventions like doing an angioplasty or draining urine out of a kidney that is infected. The other one was large core breast biopsy. And the third one was tumor embolizations, where we go through the arteries in the groin, go, let's say, into the liver arteries, and we inject chemotherapy. These are very invasive procedures. See, the goal is not necessarily zero pain, zero anxiety, but to make it manageable. And often we see that at the end, patients are very, very proud that they got themselves through that. But when we looked at the standard care groups of, this were 3 prospective randomized trials with over 700 patients. So in the standard care group in these trials, pain and anxiety went up over time. And that was pretty much unaffected of how many drugs they got and how invasive the procedure was. But if you just read the script in the beginning, this increase in pain and anxiety over time didn't happen. So that makes it very, or shall we say, effort effective for the staff. And, these procedures sometimes go over hours. So you kind of provide a patient a coping mechanism that then they can use. And we've seen patients come back for other procedures where they may use that on their own.
And I'd like to know if in your study, you find out about the main negative effects of anxiety before the surgical and dental procedures.
We published about that too. So there's not much we haven't published about. So if anybody who is interested to read more on our website, comforttalk.com, we have a whole summary with little executive summaries of what we found that go more into detail. But patients who are more anxious, they're going to take longer. They typically request more drugs in a setting where you can get more drugs. And they typically will have more pain and more anxiety. But they are also quite responsive to a hypnotic intervention. Because keep in mind, if your mind is so active, it can make up a horrible scenario, it's also very, very good in changing that scenario. So it's a built-in mechanism. If you have a patient who say, oh yeah, doc, just go ahead. These patients, fine, yeah. They're not getting too excited anyhow.
Do you use anything to test the anxiety of the patient? You test the hypnotizability of the patient to do this script, or you use anyway?
No, we don't test. I mean, there's one little thing you can use if you do. I mean, learned that from David Spiegel. We use the eye roll, where on one, we invite a patient to do one thing, they can look up, so they look up. On two, do two things, slowly close their eyes, take a deep breath in. On three things, breathe out, relax your eyes, and let your body float. Yeah, floating right through the table. Now, hypnotizability does correlate with how high people turn their eyes up. So sometimes you can see a lot of white. That means these people are pretty hypnotizable, which is actually important to warn your staff when you teach them. Because one day, one of my research assistants came and said, oh my God, the patient's eyes went up. I didn't see the eye anymore. Are they going to be stuck? What did I do? I said, no, it's fine. It's okay. The patient's just very hypnotizable, yeah? But that's why you also at the end always have to have them relax the eyes again. I know in the hypnosis society, so for research, there's a lot of debate. Should you test hypnotizability? I mean, for us, it doesn't make a difference. We offer patients to relax or comfort talk anyhow. The problem is if you test it up front, are you going to be biased? On the end, if you test afterwards and the patient was in an attentive control condition, that's the one thing that affects how they will rate the hypnotizability. So that's a bit of a drawback, but it also shows, and we wrote a paper about that, if people just want to be nice but don't know how to, it actually can make a patient unstable clinically.
Perfect. And you mentioned about the comfort talk for the patient, and self-hypnosis is a way to make the patient more comfortable before dental or surgical procedures. What is self-hypnosis, and what is the best way to practice self-hypnosis?
I mean, there are many ways to do. We did a little app. It's actually free. Comfort Talk Pro. It's the app we used in the clinical trials. And when COVID started, we just made it free. It's in the Apple Store and Google stores. It's very quick. It's just anywhere between 6 and, depending on which combinations you choose, between 6 and 13 minutes. But it's made for the people we deal with who don't have much time. And let's see, if I wake up in the middle of the night and when I fall asleep, I listen for about 6 minutes and then I'm usually out, yeah. Obviously, there are other, apps, or you can just do it on yourself. You develop a ritual. What do I do? The eye roll works really well because it's just 3 things you gotta do. You focus on floating. You go to a place where you enjoy to be in your mind. I mean, that's kind of how I do it. Or some people, may use the meditative approach to just breathing in and breathe out, focus on their breath. I think meditation is much harder because you get easier distracted as compared, and I think it is in a certain way pure meditation where you just observe what you're doing is a somewhat dissociative process. I personally prefer more the integrative processes where you get completely into a scenario that you enjoy or that you want to work on. So we have seen very rarely cases, very rare, in these 30 years where a patient knows exactly what it is and is afraid to do it because there may have been perhaps in some past been abused in a hypnotic session. You get into this whole issue of cults and you name it. But that's very, very rare. Obviously, since what we do has to go very fast, our explanation of what it is typically done while you walk the patient from the waiting room to where they're going and say, well, we kind of start out, we want you to help us so that we can help you to have a better experience with this procedure. I mean, it's a little bit of a confusional explanation of it, but it's really what it is. All you can do is helping patients help themselves. And say, it's a form of focused concentration, like getting so caught up in a book or a good movie or getting lost on the internet. And, you're in control of it. If you don't like it, you close the book, you change the channel. Same thing here. I mean, has that ever happened to you? And most people will say, yeah. I mean, yes, I like to read, or, I go to the internet, or I, do this or that. And then we immediately put an immunization into the situation and say, well, listen only to suggestions that are helpful for you, and the rest just let go by. So that's a big immunization, and use all the sounds and noises in the room to deepen your own experience, because there are going to be interruptions. So now the patient has a permission to tune out what you say. And keep in mind, you always can return to your natural state of awareness by counting backwards from 3 to 1. So if then you have permission, you go ahead. Now, key thing is if a patient says, I don't need that. Beautiful. That means that patient just explained to everyone, I can do it on my own. This is an amazing way of ego strengthening. So you say, that's great. Yeah. Why don't you just go and have your own experience and do whatever helps you? Yeah. So that's about the approach we have. And as you see, it's pretty fast.
Comparing the comfort talking and other strategies to the standard care strategies to take care of the patients before a surgical procedure, how better was comfort talk comparing to these standard procedures?
Well, I mean, comfort talk while the patients kind of come to the procedure. And so we found they have less pain, less anxiety, and require less drugs, which is particularly important with children. Because when they come for repeat procedures, there is concern about brain development if you give too much anesthesia. The other interesting thing is we started to train entire teams, like let's say MRI, and just use the standardized training approach, but then we left it to personnel to use it or not. But interestingly enough, what we found in these practices, they had a better patient throughput, and the patient satisfaction was higher, and the no-show rate went down, which was kind of surprising. I mean, how come you're affecting people who even aren't there yet?
Yeah.
But even in large communities, the word gets around. We found that in Boston. I mean, patients talk to each other. Their referring doctors talk to each other. They don't want to send a patient somewhere where they don't get the exam done. Yeah.
Yeah.
So we do find that there are culture changes that happen in the teams we trained that continue to persist, years after the training.
Really amazing. And you mentioned about the pain. Why comfort talk? Why self-hypnosis can help the patient to manage their own pain?
Well, pain has many aspects. There's the physical stimulus, but then is how it's processed in the brain, and then what does it mean to you? And so you change a lot in what does it mean to you. Also, there's now a fair amount of nocebo research that's being done. And, if you look at this pain going up over time under standard of care, it's probably an evolutionary trait. I mean, always talked about that we are primed through evolution to assume the worst. if millions of years ago you're in the savannah and there's a sound, and you may say, oh, it's nothing, yeah? Or you say, oh my God, it could be a tiger. I should do something. Sometimes the person with the tiger is correct. So our genes had a higher likelihood to come from people who had a paranoid tendency of situations. And there had been studies done, since psychology students, we have to do that for credit, where they give them little pain stimuli where lights flash, yeah, and then later just the lights flash and the stimuli comes, but there's no more stimulus, and they will report increasing pain over time, even if it's not there. And a lot of nocebo research has shown the expectation. And if you're in a clinical case and you once had a clinical painful stimulus where you thought so, all the others are going to be interpreted even more. And an ambiguous stimulus is definitely going to be interpreted as painful. So that's why it kind of works.
What is the most incredible case in your clinical practice where hypnosis has provided a great benefit to a patient? I'm sure you have many cases.
Well, I mean, there's that one case we did with Dr. Eleanor Laser. We wrote a book together, Patient Sedation Without Medication, and Ellie trained our first team at the University of Iowa. And so we one day had this patient, it was an elderly patient who had a bad liver. And so when you have that, you can get blockages of the blood in your esophagus, and then they can pop open and it can bleed. So this gentleman had had a bleed before. The main vein that usually drains into the liver was blocked, and that's the vein that would have usually drained out the esophagus. So he had had some treatment already from endoscopy, and then one day he was bleeding again. And so they said, okay, I should be doing a procedure where you open up this blocked vessel. And I said, that's fine. But it was like 4 o'clock in the afternoon. If you attempt to get an anesthesiologist at that time of the day, it's very, very hard to do because they're either all still in the operating room or they're at home. So I said, hey, Ellie, we gotta need to do this under hypnosis. So Ellie started this hypnosis. We started a case. And just to tell you, you go through the neck vein, yeah, you put this like really big device in there. And then you poke in the liver from the vein that goes, you go through the heart, you go into the liver, you poke out, and then you have to poke out, and hopefully you poke into where there's still some open vein left. But it's a somewhat blind approach, yeah. And so Ellie was doing the hypnosis with the gentleman, and she asked him, well, where do you want to go? Where did you always want to go? And he said he was never in New York. So Ellie and the man went to New York, yeah. They saw all the sites. They went to all the great eating places. And then he wanted to see the Statue of Liberty. So Ellie got the idea, oh, why don't you become the statue? Because, all the statues at some point do need to be repaired. And, statues don't move and they don't experience any discomfort. So our good man was the Statue of Liberty. Ellie was doing her thing. We were poking our needle out. And sure enough, the first poke, we hit into an artery and there was blood spurting out of the thing. So, put my thumb on the needle thing to tamponade it. We were thinking, we have to think about this a little bit. So I said, Ellie, you gotta shut up here for a moment, yeah? We have to think. So Ellie told the gentleman, well, all big statues sometimes need to be repaired, and the international repair team is here now, and they're discussing what to do next. So Bill Barnett, my chief technologist, and I, we figured out, okay, what we're gonna do. We figured it out, and we opened this up. By the way we figured out how to do this by putting some contrast medium into bile duct was so cool as a way to find that vein where we had to get into that. We actually published that later, yeah. But obviously in that moment, the hypnosis that Ellie had done with that man who really was like the statue helped us to remain calm. So we fixed it. It was all perfect. The gentleman was done. So it was time to move back off the table. So he wouldn't move. He had this little smile, but he was completely stiff. My nurse was completely freaking out, thinking the patient stroked out. I was a little concerned for a moment too. And I thought, I'm going to the M&M, that's the Morbidity Mortality Conference, and explain and gonna be asked, you did this case, how? With hypnosis. So Ellie got a bit scared too. But then she, patient didn't want to come back out of hypnosis because he really liked it a whole lot. So then Ellie remembered that the gentleman had a wife waiting for him to call him in the nursing home. So she said to him, your wife is waiting for you to get this phone call. And so he came back, moved over to the table, and he was perfectly fine. So that was like one of our big cases.
Yeah.
Half a year later, since it was my patient at the time, I get notices when patients come back, and he did well. He didn't have any more bleeds. He came back in a diabetic crisis in the hospital. So I see on my screen, patient came back. I thought, oh, I'm going to go up and visit. So I read through the patient chart. And while he had this crisis of his blood sugar completely out of control, the treating resident had written in the note, and we found the patient in a strangely statuesque position in the room. So I realized when the patient was again in serious distress, he went back into that. So I would say this story has the maximum of all.
Yeah, it's an interesting story. Sure, interesting story. Dr. Elvira, I'd like to know the last question. How do you see hypnosis in the future?
I think there are two routes this is gonna go. And just a few weeks ago, I was visiting Stanford. We were actually doing a training there for the radiation oncology team. And so I visited with David Spiegel, and we were both joking, saying, hey, look at that. It only took us 30 years starting the whole thing at Stanford before we can now bring it back, before I can bring it back now with Comfort Talk. And as you know, David Spiegel now is very much into, they're working on their app, but making hypnosis available for a large segment of the populations who may be anxious. My niche is still to bring it in hospitals for frontline medical staff to help in these very specific niche situations that we're working in, where patients come in this situation that is going to trigger all their fears. It's not necessarily the motivated people who at home going to do meditation or whatever, but the people who need it on the spot. So, and there are now other places that participate in both of these approaches. And we see their inroads. I mean, I was at Euroanesthesia 2022 last year in Milan. It's an international meeting where I'm in the anesthesia session, listening to things where suddenly people advocating anesthesiologists, you should not use negative suggestions. You should be using different wordage, and you should provide a patient more comfort. So I see people using the Comfort Talk principle. Since Comfort Talk is kind of a trademark, they're using some other ways around to call it. But I mean, it's very rewarding to see. I mean, it's a movement. I mean, I'm not the only one, and you interviewing a lot of people who are in the movement, in your podcast. But it is changing, and I'm really delighted to see that.
Yeah, I think hypnosis will be a bright future in the next upcoming years for sure. And you were one of the person who helped to hypnosis can be seen nowadays in a serious way because your work, your research, and your clinical practice of many years. And I'd like to know, Dr. Elvira, how can people find out more about your incredible work?
Well, we have a website, Comfort Talk, And there are a lot of examples. There's all the research, there are some videos, there is learning materials. They can download some free excerpts of how we do our online class. They can get a free chapter of our book. We have the free app. So it's pretty much all on the website. And
It's comforttalk.com, right?
comforttalk.com. Yeah.
I feel very honored to have you as a guest today. And I hope to talk to you soon about hypnosis and your incredible work.
Well, thank you very much. It was just a delight being with you.
Thank you.